I think we have something to learn anyway. How can I expand? Okay. This is a case of distal left main disease associated with multi-vessel disease and poor left ventricle function. This is the clinical problem, female, 81 years old, family history as risk factor as well as diabetes and hypertension, clinical presentation, no previous history of coronary artery disease, admitted to the hospital for heart failure in March, last March. Blood pressure was 135 systolic blood pressure. Heart rate was 110 beat per minute. Saturation was 92. ACG, you see diffuse ST depression. And echo, depressed left ventricular fraction, ejection fraction was 0.35 with severe mitral regurgitation. Other comorbidities, COPD, mild chronic renal failure, and previous stroke as well. And this was the angio. Diffuse disease on right coronary artery, distal left main, proximal LAD, proximal circumflex, and also somehow distal left main, distal LAD. So if we go for Euroscore, logistic was 72 and standard 14 with syntax score 2. Mortality you can see with syntax score 2 very high, with PCI mortality was 28 against 29 surgery. So not that much good patient also for surgery. If we look on the complexity of PCI have been reported this morning, I think this is what to consider really complex because of comorbidity of patient, because of left ventricular function, poor left ventricular function, and of course the bifurcation, distal bifurcation with diffuse disease is taking it more and more challenging. In complex coronary disease, this was not in cardiogenic shock, but it was in pre-shock because that mean was moving to a shock because of blood pressure and because of the saturation and the heart failure, which was admitted to our hospital. And of course, if we look on the indication about what is preferred for these patients, of course, surgery is preferred, but it is not a rule. That means if we discuss with the cardiac surgeon and we see what is the problem in this patient is not only coronary, but comorbidities and the high risk of also for surgery. We know some pro and contra for both coming from guidelines. So we have the discussion with our surgeon. Of course, medical therapy is not realistic in this patient. Surgeon was reluctant because of high surgical risk, because of all the comorbidities and, of course, renal dysfunction. High risk, but no other option to be pursued. Now, I think the first strategy is to make your procedure safe. And I think in this patient, the first key point is the mechanical systemic support. Because without this, I think this patient cannot go out from cath lab. So we decided our strategy with to implant Impella. before starting anything. Bilateral femoral access, then impella, then 7 French guiding catheter, because I think in femoral approach, because this you can expect many difficulties. Many times you might need to cross with 2 balloons inside the catheter, so you have to take any precaution to be comfortable with your procedure, even if the risk of bleeding will be increased by femoral approach as compared to radial approach. And this is the anatomy. See that distal lift main, ostial LAD, and also proximal LAD, as well as circumflex here. It is not moving, but we have some problem with the moving. But anyway, this is showing the impella, and this is what we have also with IVUS, because the patient was stabilized by impella, so we were able also to go with IVUS and to see whether we can go for simple stenting, that means provisional stenting, leaving everything for a second stage on circumflex, or we have to go for 2-stent technique upfront, 2-stent technique. From IVUS, the extension of disease was shown on both sides of both branches, that means LAD and circumflex, and distal lift main was significantly diseased. So we decided to go for 2-stent approach. We wired both vessels. We started to treat the mid-LAD with a significant stenosis here. You can see that pre-dilated, then stented, and again, after treatment of mid-LAD, we went to distal lift main. The strategy here was to do something that you can do very quickly without complication and with, let's say, with a very secure final result or immediate result. And I think in this case, the modified T approach, that means like a reverse step, can be the best thing to do, because it will give you the security that will be coming out with good immediate result. So what I am using here is a stent in circumflex with a balloon in crossover from lift main to LAD. This is just to match how much to protrude, that means, or to be sure that I'm covering the ostium of circumflex with the stent. And in order to be like this, I mean, to be sure, I think at least maybe half a strut or 1 strut will be protruding in lift main. And this can be shown in angio, and you can see that now we have in position both stent and balloon. Now the stent will be delivered at high pressure, and then retrieving the delivery balloon system or balloon in a bit in lift main, and doing first kiss with already there the balloon already positioned in crossover from LAD to lift main. This is in order to be sure that you might flare what is protruding not inside the stent, but outside of the stent. That means not on the orifice of side branch, but distally. So now separately, then after kissing balloon, we inflate the LAD balloon at high pressure, And we're going with another bigger balloon, 1-to-1 balloon, in order to be sure that everything is well opposed before putting the second stent, in order not to have any difficulty to go with the second stent. You see here, again, with a bigger balloon, going for flaring the stent to distal outside of the orifice of side branch, and now going for stenting left main. So the whole procedure, the whole technique is, as I show you, stent inside branch and balloon. Then after stent and balloon, you go with the bigger balloon, or the kissing balloon and bigger balloon in main vessel, in order to be sure that you are opposing the stent very well. Then putting the stent in main vessel, that means left main to LAD, and after this doing pot, crossing the stent to circumflex again, and doing a second kissing inflation and the final pot, in order to be sure that everything in place. And of course, this is should be also mandatory checked by IVUS, particularly in this case, if the patient is still stable. Fortunately, the patient was still stable. We checked our final result, and you can see that everything in place. Areas are good, the minimal luminal area are good, both at branches as well as confluence side, as well as on left main. Good opposition, and good expansion of the stent. And this also confirmed by a simple stent boost, as you can see here, with no deformation, no overlapping of stent, nothing of this stent is crushed by the other one. That means that we are still doing something called modified T. There are so many modifications of T stenting, and I think that this is good to keep in mind in order to have something quick and let's say effective in treating patient in emergency situation or in difficult situation. I know many of you will go for DK crash or for culotte, or me too, but I think in this case, in particular in this case, I think the good choice is to go for easy, quick technique. And this is the final angio. You can see it was very good, very satisfied with what we have done. So at the end of our procedure, stable hemodynamic conditions, blood pressure is still on 130 to 80, and now saturation was 97. Impella was removed. Patient was transferred to coronary unit, and patient was discharged in hospital event-free after 2 days from his acceptance. She expected to come back in September for right coronary artery second step PCI to complete revascularization. But of course, we will decide accordingly to the situation, the clinical situation of the patient at that time. So my final remarks that high-risk patients are not the ideal candidate for PCI procedure or for surgery as well. However, in some patients, PCI represents the only option in this patient. Preventive use of mechanical support is crucial, and to complete the procedure safely for patient safety, of course, and can allows you to have some time more and have stable patient on the table. Make it simple as much as possible, but do all what is important to do to optimize your work. Adequate lesion preparation, stent deployment, and final optimization is very important in these patients. I would highly recommend it at least for final optimization when you can prevent event at follow-up. due to stent under expansion. Thank you very much for your attention.